Thank you so much. Thanks everyone. Thanks the organizing committee for having me here. I also do appreciate the interspersing of the clinical and the translational science talk, which I think is fabulous to really keep educating each other, yeah? So, okay, I will talk about lobular breast cancer. As a brief introduction, lobular breast cancer is the most common histological subtype of breast cancer. It's 10 to 15% of all breast cancer, and because breast cancer is so prevalent, in the US, it's approximately 30 to 40,000 new cases a year. The most obvious clinical differences are that it is diagnosed at an older age, the tumors are larger, they are more late stage, they are almost all ER positive, they are multifocal and bilateral, or often multifocal and bilateral. There are unique aspects of metastasis. The patients have more later recurrences than patients with IDC. There are also metastases to like bone and brain as the most frequent site, but there are unique sites of metastasis in the ovary, in general, I would say, in the GI tract as well as in addition to the ovary. The enrichment of NF1 and HER2 mutations, and there are also more frequent mutations of ER, but that's not different to IDC. We start to understand unique biology. I think the one point we really have nailed down now, although we still need to make more use of it.
So thank you. I think I've never had the honor to speak after Dr. Oesterreich, and it's really a great honor. And you will see that in my slides. I will repeat some of the things because she did such impressive does such impressive work in that area, in that field. So I'm going to slow down. We had a lot of speed coming from Verena, from Dr. Kiewer to Professor Kümmel, and now a lot of molecular data from Professor Oesterreich. And I will go to what's important for invasive lobular cancer from the clinical perspective. And I can tell you, actually, there is a lot of things that are important, but you can rest. The data that is out there is unfortunately very, we don't need much time to look at that. So these are my COIs. So I will start out just a quick basic tour, and Professor Oesterreich just showed that. So ILC is really something different than IDC. And this is something that in clinic and I think not in our tumor board, because we pay really close attention to that. And there is fortunately a growing awareness that these are really possibly two complete distinct entities. And because they stem from different kinds.
Envision, I am Adrian Lee. So actually, Adrian is my husband. We are very, very excited to look forward to coming here, especially because this is actually my alma mater. I got my degree here a little bit more than 30 years ago. Can't believe it's more than 30 years ago. And anyway, he did his back and he couldn't move an inch and he was laying in bed. So anyway, it's on my own and I'm going to give his talk. So I'm going to talk in this on endocrine resistance. You already heard a great talk from Matt Götz today, early in the morning, and I think he summarized really nicely, especially focusing on CDK4/6, PI3 kinase, AKT, and estrogen receptor mutations. I do think estrogen receptor mutations are really, really important and are the major cause of resistance to hormonal therapy. So I'm going to focus on this in my talk. I am not so much talking about these single nucleotide variants, because I do think you might actually hear more about this in the subsequent session. But I will also talk about different ER mutations, and this is shown here on the slide. So this is estrogen receptor activation function 1, 2, DNA binding domain, hinge, and I think most of you in the audience are very, very familiar with these point mutants. You can, everybody's familiar with the point mutants in the AF2, but in addition to these single nucleotide variants, we have two other